So it gives me great pleasure to introduce our chair, Dr. Helen O'Neill. Helen is Chief Executive of Hertility Health and a lecturer in reproductive and molecular genetics at University College London's EGA Institute for Women's Health.
Fertility patients in England have spent the past essentially 2 decades at the mercy of a postcode lottery. And so this situation we would have hoped to improve, but it didn't when the NICE Fertility Guideline received its last major update back in 2013. So it actually remains to be seen whether the situation will change when a newly updated guideline, currently under development now, is published by NICE in 2024. So meanwhile, in July of 2022, the UK government made a commitment in its Women's Health Strategy for England to greater transparency of the provision of IVF services across the country. And in doing so, to publish data nationally on provision and availability of IVF. As yet, these things have not yet happened. So it gives me great pleasure to welcome our first speaker, Professor Dame Clare Gerada, President of the Royal College of General Practitioners and co-chair of the NHS Assembly. Clare co-chaired the project that produced the report, A Women's Health Agenda, Redressing the Balance. So over to you, Clare. We're delighted to have you.
I first became interested in this area when a patient of mine had 12 cycles of IVF, and this was way back in the 1990s. So it was a very difficult, very dangerous process. And she was basically left in a great deal of debt and distraught and childless. And I then became aware that nobody was asking women about their fertility choices, what they wanted, a lot of the patients I was seeing had no children, but nobody was asking. And I began to ask routinely women about when they might think of starting a family. And through that, I developed an interest in fertility treatment, and I became the GP that patients came to see. And what I learned was back then, and is still the same now, is the shame, the stigma, the secrecy, and the fact that unless you ask, it's unusual for patients to bring it up. And even when they do bring it up, it's usually quite late on and it's done in great distress. I suspect that very few people know that women are entitled to 3 cycles. Absolutely, because nobody gets 3 cycles. It's barely lucky if you get 1 cycle. And over the years that I've been a GP, the rules have changed so much that even I'm confused. Not long ago, you couldn't refer a patient who was obese, who was a smoker, who had a living child, even if that living child was by their new partner and that living child was well into adulthood, i.e. was somebody that was an adult in themselves and the woman hadn't had a child. The rules are about you had to be under 40, then it was under 39. In other words, you couldn't refer somebody who would be 40 by the time they'd be seen. So the rules change. What I've tried to do as a GP is always bend the rules and to be slightly ahead of the game. So, for example, when we could, to prescribe the medicines on the NHS, even though the patient might be going privately, I would always give my personal phone number and tell the patients to contact me, because the mess and the confusion and the fact that notes get lost, results get lost. So I would make sure that I held on to the patient, certainly throughout their treatment, and sometimes very happily beyond into when they had live babies. The problem for GPs isn't that I don't think we're sympathetic to this, it's because society is not sympathetic, and we bring up the prevailing mood of society, that if no one talks about it, if no one is lobbying on behalf of couples or women who are trying to have a child, it becomes very difficult, and it then gets put into the margins. And I was reflecting before I came here, I'm on a lot of meetings about the NHS, a lot of meetings, 2, 3, sometimes 4 a week. Never has fertility treatment been mentioned, never. What's mentioned is the menopause, what's mentioned are treatments, contraception is mentioned, puberty is mentioned, but never in the last, well, as many years as I can think, is infertility mentioned. So I think we need to hold on to that and to think, why is it not being mentioned? So how can we help? How can my profession help? I think we can help by helping lobby on your behalf, on our patients' behalf. I think we can, when I was co-chairing with Leslie Reagan, the PPP report, which you mentioned, we made 2 recommendations. One was to stop the postcode lottery around funding for infertility treatment. And the other was clear guidelines for patients as to the add-ons, which are a disgraceful aspect of this area. So how can we lobby? I think it's important that we take this into the medical establishment, into the medical royal colleges, because if this was any other condition, the fact that women and men are being sold inappropriate treatments by organisations and systems in any other area would have been stamped upon. I think we can lobby to get proper nice guidelines on this. But also what's really important, and this is something that I think yourselves can do, we need better information. I have been a GP in the same area, and even I struggle to know where to send my patients. And sadly, most of my patients, I have to advise them to go privately because of waiting times on the NHS. But even I struggle to know who's best, who's honest, who doesn't, who has reasonable and honest outcomes, and who doesn't try and sell the patients treatment that they can ill afford because they can ill afford it anyway. So as a GP and somebody who's very, very senior in general practice and probably now in the health service, I will do everything I can to try and help further, because when I was chair of the Royal College, we tried to lobby, in fact, then for getting 2 cycles done. So I'm here for women and men who can't speak for themselves for all sorts of reasons, and to help organisations that speak on their behalf. But I would also ask the question, why do we spend more time discussing the menopause, which on the whole is not an illness, it's just a process you go through like menarche, more time discussing the menopause, more time destigmatising the menopause, which I never considered to be a stigmatising process, by the way, and no time discussing infertility.
What clout do you and other GPs have in changing access to NHS-funded fertility treatment?
We do have influence because many GPs are now sitting in what's called integrated care services, who hold budgets, but we have soft influence. We can start to write to commissioners and to say, why are we not getting infertility treatment managed so effectively? Why are women and men, but predominantly women in this country, spending £400 million per year on private IVF when they should be getting that on the NHS? But I think it's mainly through the Royal Colleges. I think this is something for the Academy of Medical Royal Colleges. I also think it's something for the Royal College of Obs and Gynae and the Royal College of GPs to start lobbying ourselves. And I will take that on board when after this, to see what we have done in my own college to promote access to infertility treatment. But I think it's an existential issue because, and I hope some of the speakers will bring it up, why is it that we don't care about infertility enough, that we don't even talk about it?
Next, we do have Steve McCabe, Member of Parliament for Birmingham, Selly Oak. Steve has sought via questions and proposed legislation in Parliament to improve access to NHS-funded fertility treatment.
I think it's about 6 or 7 years ago now since I first started raising some of these issues in Parliament, particularly about access to IVF, and that was brought to my attention by a constituent who told me a pretty sorry tale about the way she felt she'd been interrogated about previous relationships, her weight, her partner's weight, things that didn't really seem to have a great deal of bearing on it. I mean, I think this issue about the partner's body mass index is something that's annoyed a great deal of people, because there does seem to be some questionable medical value in it. In fact, I think there was a petition signed by about 2,500 people on it just last year complaining. So that's kind of how I got into it. I should probably also say that my own daughter was born as a result of assisted conception help we had. So, it's something that I have some sensitivity to. And I heard Clare talking there about the guidelines. I mean, I think the problem with the guidelines, as far as I can see, is that unless the guidelines are a minimum, that that are going to be enforced in some way, they're absolutely useless. And at the moment, you know, there is an infinite capacity for the ICBs to add as many conditions as they like. So you might as well not actually have guidelines, it seems to me. And that means effectively access depends on where you live. It is a classic postcode lottery. And in fact, the last time I checked, I don't know if it's changed now, the two best places in the country to live were Thurrock and Luton. So if you want to quickly buy a house there, that's the best place to get access. But actually somewhere like Birmingham or the West Midlands was actually pretty grim. I'm a Birmingham MP. Now, I'll have to confess, I haven't been so focused on this issue in the last few months following the pandemic. And I think that is symptomatic of the difficulty we might be about to face. I think there's a real danger that access to IVF could just slip off the agenda completely, given the current state of the health service. And, you know, it's quite a big issue, because fertility it's thought to, I think, affect about 1 in 6 couples. If left untreated, it can lead to a whole lot of other conditions, both things about stress, anxiety, depression, relationship breakdowns, but other chronic health conditions as well, and that all adds to the cost. I personally think, although IVF cycles are expensive, I think we've made it rather easy for ICBs to use price as a major factor in this. And, you know, I can't understand why we can't have better commissioning, why we can't have some central attempt to set prices, why we can't insist that ICBs combine and commission on a much bigger basis. I don't really accept that we are doing this. And I can't think of any other recognised medical health condition where we would allow people to go without treatment on the basis that we're saying we can't find a way of commissioning to bring the price down a bit. I mean, almost every day or every week in the comments, there's some argument about some drug or some treatment where we're engaged in that basis. And it seems to me that's the problem. We did hear, I think Helen mentioned the health strategy in 22, which promised all sorts of things: access to information, better help for same-sex couples, the removal of certain barriers. Actually, none of that has come to fruition, as I can see. And basically, you know, people who suffer with infertility problems are just victims of rules and decisions, which, as far as I understand, we would find intolerable if we were discussing almost any other medical condition. And like Claire, I do wonder why the attitude is that. And I wonder if there is a kind of danger that there's a kind of age issue playing here, where people in the past had to put up with it, so you should too. Now, I don't know if that's the case, or if it's just regarded as something that doesn't get the same priority, but it is a WHO recognised condition. It seems to me it should be treated. Now, back in about April 2018, I introduced the 10-minute rule bill in an attempt to try and give shape to some of the minimum measures I thought were necessary to improve the situation, and that sought to ensure that guidelines and standards would be followed by, in those days, all clinical commissioning groups, now ICBs. It sought to prohibit the use of eligibility criteria which was based on non-clinical factors. And, you know, I think the idea that you may have had a child by a previous relationship who you might not have seen, or who is now an adult, is a pretty good example of that. And I argued that there should be some attempt to create either a national tariff or at least a common cost base for those provisions. My view is that we're still in that position today unless we bring in something like those as minimum measures, and unless we get this back on the political agenda. And to that point, I think Clare is right. I would like to see cross-party agreement that IVF should be in the manifestos of all parties so that it actually gets its proper place in the NHS, whoever wins the next election. And I fear if we don't do that, we're actually going to see NHS treatment for infertility virtually disappear, and it is simply going to become a case of help for those who can afford it.
Could the Labour Party include improving NHS fertility services in its manifesto for the next election?
Well, I hope we will, but what I'm actually saying is we would have much more impact if we could actually have a campaign now that sought to get all parties to include it in their manifesto, because it would be much harder for people to wriggle out of it then. I think we need a commitment across party that it should be in the manifesto. I'll certainly work with Labour, but we've also got to straighten out where the responsibility lies. Unless we actually give some clear direction about what the minimum expectations are over access to IVF, it won't make any difference what is the manifesto, because as long as we leave these loopholes that allow ICBs to do whatever they choose, we're just passing the buck effectively.
You have campaigned on this issue for a long time. Why do you think there's been a frustrating amount of progress?
So I think one thing is the rapid turnover of ministers. So it's got to get a higher political significance, and that means you either have to keep someone in post long enough until they deliver on it, or we've got to elevate it to a higher ministerial portfolio. I think that is one of the problems. I think the other problem is that there's not enough ownership. There's too many bits of the NHS are able to move, pass the buck and move ownership around. So I would like to see a minister in position with a set of demands that they've got to meet, and then a tightening of the NHS commitment around the different parts of the NHS so that we could guarantee delivery rather than promises. Either we're going to accept that this is a medical condition and it should be treated like any other serious medical condition with consequences if it goes unattended and untreated, or we're going to say, well, this is just an unfortunate byproduct for some individuals and we're not going to devote enough. It's not a priority for us. We've got to make a choice. I would say we should see this as a significant and serious health condition, and we should make sure you get the same access to treatment as you would if you had a heart condition or cancer or something like that.
So our next speaker is Penny Mitchell. Penny is the Director for Population Health Commissioning at the NHS North Central London's Integrated Care Board. She leads work on policy areas, including the North Central London fertility policy.
I'd probably like to note that every integrated care board is different. So I am very much giving you a snapshot from the work that I've been involved in. And with the establishment of integrated care systems, we're hoping that there will be much more of a system-orientated approach. This needs everybody to be working together, and with our counterparts, from politicians, local authority colleagues, voluntary community sector, but most importantly, our communities and our residents and how we're working there. These are a new part of the NHS, although they were formerly known as clinical commissioning groups, or CCG. So that might be some language that some of you are more familiar with. And we're responsible for planning with our system partners as to how we address the health needs of our residents. I'm working as part of North Central London, and we work for around 1.5 million residents in 5 of people across 5 boroughs. It's an incredibly diverse area across all sorts of demographics, age, race, ethnicity, social demographics, etc.
And across that, we're responsible for adult services, children's services, services in the community, services in the hospitals, and many other settings. And relatively speaking, fertility is quite a small area in terms of sort of levels of activity, if you compare that, say, to, for example, urgent care services. However, we know that for those people who need support with fertility treatments, that this is an incredibly important and sensitive area. And so I wouldn't want to diminish that at all. And so we're going to talk about sort of fertility policies, but I think it's important to recognise that most integrated care boards, when they're talking about fertilities, they're very much talking about the specialist end of the pathway. So there's lots of support, advice, tests, investigations that could be part of a person or a couple's journey to have a family. But in terms of when we're talking about cycles of IVF and clinical criteria or non-clinical criteria to access certain fertility services, that's very much about these specialist treatments that are provided. And a fertility policy that's set out by an integrated care board is typically saying what type of fertility treatments at that specialist end are provided and what the clinical criteria will be to access them. So why did we in North Central London look at this and start to act recently? The NHS has obviously gone through a lot of change. And for us, as I mentioned, we used to actually be 5 separate CCGs. So each of those 5 boroughs in North Central London organised and planned their services separately. And each had their own fertility policy. And similar to many other places, they dated from about 2013-14, which is just after the last NICE update to their guidance. In 2020, we formally merged as a CCG, and then subsequently last year, we became the ICB. And we still had those 5 fertility policies in place. And as has been mentioned already by others, and I'm sure many of you listening to this might have experienced, there were similarities between them, but there are also some differences. And also I think it's fair to say, you know, the world has moved on since 2013. Things move at pace, both in terms of clinical developments, but also views in society. And so we really wanted to focus on how we could change things to benefit our residents in terms of more equitable access, better clarity and consistency in terms of what would be provided and how people could access it, and also therefore hopefully improve some of the patient experience when people are going through these pathways, although recognising it's always going to be really tricky. So how do we go about doing this? Well, this slide is an incredibly simplified overview of what was a huge amount of work. And if only I could thank the number of people who were involved in it. And I'll be honest, our timing wasn't great. COVID interrupted, so it did make things longer. But there was a huge amount of work that was undertaken. And it's important in these areas to be really robust and to be really rigorous and make sure that you pull in the people you need and undertake the level of investigation that you need to. One of the things that I will do is shout out for the clinical reference group that we set up, which was a mixture of specialist fertility clinicians on our patch and some GPs who really led our work to make sure that we had that clinical focus. And also we had an independent clinical specialist from a different area to support us and give us an initial view. So first of all, it was very much about understanding what our position was and understanding what the guidance was around this area. And the NICE guidance, obviously a key part of that, but also linking in with others like the UK Fertility Network and undertaking a lot of modelling to understand what the position was, understanding our demographics, etc. And also initially engaging with our residents. That moves through to a set of recommendations, which we use to develop a draft policy. And then we moved through, took that draft policy out for quite wide engagement, as wide as we could. And again, thanks to many organisations who assisted us with that, like the LGBT plus mummies group, UK Fertility Network, etc. Again, who helped us reach groups so that we could really discuss with them what we were trying to propose and what some of the implications would be. And then we have to go through quite a lot of processes with an integrated care board in terms of sign off to get that policy approved, make sure that we're undertaking appropriate impact assessments such as around equalities and quality before we could go live with our fertility policy. And for us, the new one went live in July last year. So whilst the policy is sort of seen as done and dusted, I certainly don't think that this is ever a sort of a closed subject. And it's really exciting to be part of this conversation. For commissioners, we overall in North Central London have received some quite positive feedback from the new policy. We believe that we do have better alignment now with the NICE guidance. We believe we're going to be providing an increase overall in terms of provision across the majority of our boroughs. And I think everybody is finding it much easier to know where to go to find the policy and have that conversation for patients, particularly with GPs. But I think we're under no illusions that this is always straightforward. I know sort of Steve mentioned that finance can be used as an excuse, but it is also a reality. We have to consider all the different needs of our populations. And I think some of the historical trends and the historical approaches about how spending has been allocated has put a lot of ICBs in a very tricky position as to how we decide to move forward and how we can increase spending in this area. For example, in the women's strategy has come out at the moment with no additional funding, although we're still waiting for more on that. We've got our providers are in very challenged circumstances. Workforce is obviously always incredibly strained, and we've also got ongoing changing provider landscapes, so we need to be mindful of that. I think patient choice is quite an interesting question on this one. And we get different views from different people depending on their experience. And I think our role as an ICB is to support patient choice in line with our duty for the NHS. But it can be quite tricky. And again, because of different areas and depending on where you live, where there's been expertise, where there are centres, etc., it can make it probably easier in certain areas, maybe like ours in North Central London, where you've got quite close proximity to quite a few centres that do have this expertise compared to others. So that's always quite a tricky one. Data, as I'm sure many of you across many parts of the NHS are aware, data can be really tricky. And the better data we have, the more informed we can be to understand what our situation is and what the needs of our residents are, as well as what the demand is. So we're always trying to work with our providers to understand our situation better, to help inform our decision making. And changes in the national landscape, we're always dealing with changing new strategies, new policies. More consistency in that would make a big difference. And I think the question about whether this should be considered more nationally is a really, really strong one. I know I've had conversations with people who work, they're concerned that ICBs might feel that it was treading on their toes, but I think a lot of ICBs would probably welcome more national direction in this area. And I think most importantly, we really do want to continue to respond to our residents with their feedback. We know that we haven't always and can't always meet the expectations of everybody, but it's something that we want to continue to work with our residents and communities to understand their needs and to understand how we can serve them better.
So we'll move on to our next speaker. Next, we have Professor Melanie Davies, Professor of Reproductive Medicine at University College London and Consultant Obstetrician Gynaecologist at the University College Hospital's Reproductive Medicine Unit. Melanie is also the Chair of Trustees at the EGA Hospital Charity.
This guideline was over 500 pages at publication and it had 15 appendices. In the context of state-funded treatment, I'm just going to draw your attention to part of the preamble, which said that commissioners and providers of healthcare had a responsibility to enable the guideline to be applied in the context of local and national priorities for funding and developing services, and mindful of the need to advance equality of opportunity and reduce inequalities. So I think these highlighted words are in NICE guidance and it gives a degree of wriggle room. So what's in the guidance? Well, for patients, as far as I'm concerned, it's all about patients. And there is on the website a lay version of the guidance. It's all freely available to read. This is the hyperlink. And it gives useful background advice and information, actually, for people who are embarking on the journey to pregnancy. What's in it for GPs? The first chapters are about initial advice, initial investigation, and onward referral. And what's in it for fertility specialists? It's the rest of the guidance. And actually, this is a complete run through of the world of fertility. And so I'm going to just broaden the context a little bit. I can give some examples of what worked and what didn't work, and I'd really like to say something positive. So I'm just going to pull out a couple of things that actually did go well. Firstly, this is something I'm proud of. This was actually why I volunteered to join the committee. We made some new recommendations about preservation of fertility for people who had cancer and were going to have treatment. And that included funding for egg freezing for the first time. That's been implemented as borne out by this national survey done by my colleague Sanya Latif a couple of years back. Everything blue on this map represents funding for sperm, egg, and embryo freezing for people with cancer. The areas with the darker blue also fund ovarian tissue storage, which is currently under review with NHS England for specialist commissioning. So I think that was a success story. And this is another one, embryo transfer strategies. So I led this topic group. We made new recommendations on elective single embryo transfer, which at the time was not that common. And we made the standard that no more than 2 embryos should ever be transferred. There was an existing campaign to reduce multiple births because of the tragedies that were occurring with pregnancy loss, prematurity, and severe disability in twins and triplets. And I think these recommendations added strength to that campaign. We've now reached an all-time low of 6% multiples in this HFEA report, and there has been no reduction in the overall pregnancy rate. So that's an achievement. But of course, tonight we're really talking about what didn't go so well. And I've got 2 examples here. Firstly, I just want to mention intrauterine insemination, because this was a popular treatment in 2013, and it was widely offered to couples with unexplained infertility, women with mild endometriosis, or men with a mild degree of infertility. But unfortunately, the evidence wasn't there to support it. So although it was generally seen as quite a successful treatment and halfway house to IVF, we couldn't recommend that it should be routinely offered. This led to a huge backlash. There were a number of surveys, such as the one here on the top of the screen, which showed that the majority of clinicians, 96% of clinics in this survey, did not agree with the NICE guidance and continued to offer IUI. But the funding bodies implemented the guidance and withdrew NHS funding from IUI, except in exceptional circumstances, and there were real concerns that smaller units might have to close. It all got a bit awkward because the author of the influential study was on the committee. NICE took it away. They did a further review on the subject, included health economics, and republished an addendum in 2016. Only a month later came this article in BioNews, which is here on your screen. This was extremely strongly worded objections to the NICE guidance. So this remains an issue of contention. There are new studies, and this is a major part of the current update. But of course, the main thing we're discussing tonight, where it really didn't go well, was in IVF funding. We started off with a brave attempt to define an IVF cycle, and a full cycle of treatment was an episode of stimulation and transfer of the resultant embryos. But this was too generous for most funding bodies, who made their own restrictions on perhaps one fresh, one frozen, and so on. We went on from defining a cycle to say who should receive it. Now, the previous guidance in 2004 had given 3 cycles of IVF treatment. There was no way that the committee, and in particular the patient representatives, of course, were going to settle for less. In the event, we actually increased access by, for the first time, recommending IVF should be extended to women over 40 in certain circumstances where the prediction was of a reasonable chance of success. And this recommendation for 3 full cycles and extension up to the women aged 40 to 42 is what's really been the difficulty. I think health economics inevitably comes into it, and it supported the panel's decisions. It certainly didn't determine them. But I really rated the health economist who was involved in this work, but I mean, they're given an impossible task. At this point, NICE worked in QALYs, quality adjusted life years. Now, you can't really do life years for an IVF baby that doesn't even exist yet. This was based on the health detriment of being infertile. So that's hard enough. And then NICE used a cut-off of £20,000 for NHS funding per QALY. Well, with that, with this modelling, based again on perhaps slightly shaky success rates that vary from time to time, country to country, we modelled that for the typical patient with tubal disease, no previous IVF, £20,000 cut-off of willingness to pay by the NHS would give these 3 cycles, it's all green, roughly up to the age of 40. And if the NHS had a greater willingness to pay and you raised the threshold to 30,000, you could put in that extra cycle up to the age 40 to 42. So that's just an illustration of how complex actually the background work was that went into this. The very last thing I just want to mention is to draw your attention to some small print in the considerations for equality. The existence of living children should not be a factor that precludes provision of fertility treatment. Well, that hasn't really gone through. And also there is a recognition here that there may be a fertility problem for women who are single or in same-sex relationships. And that too really has been under-addressed. So that was a quick run through. Certainly from my point of view as a clinician, it would be nice to have a workable guideline, and I think the current update is an opportunity to do better.
So next up, we have Dr. Chris Skedgel, Director of the Office of Health Economics.
Much of what I'm discussing comes from a research program that was funded by Ferring Pharmaceuticals, and I had a vast array of collaborators on this work. The goal of health economics is to distribute resources in a way that allows society to get the greatest value for its money out of the National Health Service. Because we're concerned about societal value, it's important to understand how does society feel about the value of infertility and fertility treatments. So, as I say, with the support of Ferring, we did some research to investigate these questions. So in the first project, we asked almost 8,000 members of the public across 8 countries about their attitudes towards fertility and whether they would support a national assistive reproductive therapy, an ART program. So would they be willing to pay a bit more in their taxes or their insurance premiums each month to support a fertility program? So with respect to the first question, what are the attitudes towards infertility among the public in these countries? I say that we included 8 countries, but the Nordic countries were so small, we've combined them into a single category here. So you can see there's broad public support for the idea that infertility is a medical condition, that having children is a basic human need. The opportunity bar there says that the opportunity to have children should be available to everyone, and infertile men and women should have access to treatments that improve their chances of fertility treatment. So broadly speaking, there's quite a bit of support for the idea that infertility is a medical condition. It's not an illness, but it is a medical condition, and that people should have access to fertility treatment. When we dig a little bit deeper and say, well, do you have any preferences over who specifically should have access to fertility treatment? We see relatively broad support for the idea that anyone who has difficulty conceiving should have access to treatment, but somewhat counterintuitively, we see much lower support when we actually dig into what some of those categories might be. So we see lower support for people without a partner, lower support for people who already have children, or children via ART. But interestingly, we see no drop-off in support, or very little drop-off in support on the basis of the probability of a successful outcome. So as I interpret this, society sees value in giving people the opportunity, even if the chance is reasonably low. When we get down to, excuse the term, no pun intended, but to brass tacks, and we say, well, would you be willing to pay a bit more each month to support a national fertility program. We find in China and Spain, a majority of respondents support the idea of paying a bit more in their taxes to fund this sort of program. Countries, the Nordics, the UK, and the US, less than 50% were willing to pay the full cost of a fertility program. But when you broaden the question and say, would you be willing to contribute something each month towards a fertility program, the majority that goes above a 50% threshold. So a majority would support paying at least something towards a national fertility program. So on that basis, we see support for the idea that the public sees value in fertility treatment, sees infertility as a problem, and sees value in providing fertility treatment. So why do we see at the same time some resistance perhaps among HTA agencies, health technology assessment agencies, and payers around paying for this? The recent work that we did found that the standard measure that HTA and payers use for evaluating the value of these treatments, health-related quality of life. So the goal of every treatment in the NHS is to improve the length of life or the quality of life for the patient. When we apply that measure in the context of infertility, so as Professor Davies pointed out, this is a difficult concept to measure. But what we find when we surveyed people who had experience of ART, so the 4 lines on this represent people who had no access to ART and therefore no success, people who had access but no success. The red line is people who had access to ART and had a successful outcome, so a live birth. And the dashed line is the control group, so people who had a successful pregnancy with no ART. And what we find when we measure health-related quality of life is that, in fact, health-related quality of life is lowest among the people who had ART and had a successful outcome. So this is a counterintuitive outcome. We expected people who had access but no success to have the lowest, followed by people who had no access and no success. What we surmise, hypothesize, is this measure is picking up the burdens of childhood, particularly people who need ART and perhaps are more infertile tend to be older by the time they access ART. What we think we're picking up here is the fact that being an older parent to a young child for the first 5 or 10 years of their life takes a toll on the health of the parent, takes a physical toll, takes a mental toll. But at the same time, what we're not measuring is the idea that there are broader aspects to well-being than whether you have a sore back or whether you feel a bit stressed about your child. There are aspects of life fulfillment, of well-being, of sense of purpose, none of which are being captured in the health-related quality of life that payers and assessors typically use. It also tends to leave out the effect of infertility across a network of affected individuals. You can imagine partners and grandparents. So this is infertility is a slightly unique condition in the fact that the impact of it extends beyond perhaps the infertile individual in a way that many other conditions don't. So in summary, the public sees infertility as a medical condition and the desire for children as a basic human need. They support access to treatment. They're willing to pay for at least something towards access to treatment. And we propose in our article that conventional health-related measures of quality of life and of value may not capture the full impact of infertility or the benefits of fertility treatment.
Our next speaker is Dr. Catherine Hill, Interim Chief Executive of Fertility Network UK. She's also an author and a journalist.
I've called my talk Cycles of Hell, and it is a nod to Dante's 9 circles of hell. Those are the circles of torment located within the earth. And I think that for many of England's fertility patients, having to navigate this nation's torturous IVF pathways must feel like being in hell. It's as if an additional torment has been heaped on top of the devastation and the life crisis that infertility brings. And the situation we have in England, it's an absolute disgrace. We are the country that pioneered IVF. We've had longer than anyone else to get it right for fertility patients, but as you'll see in my talk, we're very far from that. So it's 2023, and for me, that means I've been monitoring the IVF funding situation in England for 8 years, and it's not been straightforward keeping track of all the changes, and there've definitely been more cuts than positive moves. But this year has seen 2 reasons to be cheerful. So earlier this year, 2 areas in Essex, Mid-Essex and Basildon and Brentford, they brought back IVF. They'd removed it nearly a decade ago. And that was great news. And it actually meant that for the first time in over a decade, all areas in England now offer some access to NHS funded fertility treatment. Another big positive move came from North East London ICB, and this was the result of their harmonisation policy covering 8 former clinical commissioning groups. And they now have a policy which doesn't ration access in any way. And this is a first for England. They're the only area that does this. So it follows NICE guidelines for heterosexual couples, 3 full cycles to women under 40 and 1 full cycle to women over 40. And it also recognises the diversity in starting family formation today. So there's a treatment pathway for same-sex couples, for single people, and for step-parents with fertility problems. Now, we say this is a fertility policy for the 21st century, and Fertility Network, we're pleased to be able to say we help North East London ICB with their engagement work on this policy. But it's not all good news. Recently, we've heard that Staffordshire and Stoke-on-Trent ICB, in their harmonisation work of 5 areas, they plan to offer the worst IVF policy in the UK, just 1 embryo transfer, and that's it. And it's in this news that we start to see the darker underbelly of what's happening in England. So the most obvious way that England's commissioners ration access to NHS IVF is by cutting the number of IVF cycles that they offer. And I've called this slide Talking in Cycles because it's really important to know what you're talking about. Fertility Network's research shows that for women under 40, you're looking at the data on the left here, only a few areas offer those magical 3 cycles, just 13%. The vast majority, 87%, they only offer either 1 or 2 cycles. And over on the right, you'll see that over a quarter of areas bar women who are over 40 from accessing any help at all. This is far from the whole picture, and that's because England's clinical commissioning groups, as they were, who are now the ICBs, they decided a while ago to get sneaky and introduce an additional layer of rationing, the idea of the partial cycle. But of course, they don't call it that. They say they're offering an IVF cycle and then they don't. So what's a full IVF cycle and what's a partial cycle? Well, according to NICE guidelines, as Melanie said, the definition of a full IVF cycle is ovarian stimulation followed by the transfer of all viable, fresh and frozen embryos until a successful pregnancy is achieved. It can mean that if you've created 5 or 6 embryos, you could then have 5 or 6 transfers until a successful pregnancy, hopefully. Partial cycle, on the other hand, is where a finite number of embryo transfers is specified, and there's absolutely nothing on this in NICE guidance. So what's the picture in England if we look at partial cycles or embryo transfers? Well, this is an area that is developing. By our data, we estimate 1/3 of England now only offers partial IVF cycles, but I think that's an underestimate. And most of these areas offering partial IVF cycles, 70% of them are only offering 1 partial cycle. And that's typically 1 fresh embryo transfer and 1 frozen embryo transfer. And there's nearly 1 in 10 areas that are only offering this absolute minimum, 1 embryo transfer. You know, they're really scraping the bottom of the barrel here. And Fertility Network has serious concerns about the ethics, the safety issues, and the financial issues surrounding NHS policies about embryo transfers. There are some big questions. For example, what happens if more embryos are created than are allowed to be used, and the embryo parents cannot afford to pay for their transfer or their continued storage? Will those embryos be destroyed by the NHS? Is that ethical? I was talking to a patient last week about precisely this. She and her husband hadn't been successful with their 2 NHS embryo transfers, but they had created more embryos, which they then weren't allowed to use within the NHS. Thankfully, they did have the money to pay privately for one of these embryos to be transferred, and they were successful. But what about if they couldn't afford to do this? And another question, what about when 2 partial IVF cycles are offered? In this situation, couples who have unsuccessful embryo transfers following a first round of ovarian stimulation can then be pushed into a second round of stimulation with its health risks to the woman, an additional cost to the NHS, and they're being pushed to do that despite having viable frozen embryos that they could have used. So this isn't good medicine or sound economic sense. And of course, I can't forget to mention the other ways that access to NHS-funded IVF is rationed. And stress again, all areas in England, bar North East London, are using some of these additional rationing rules. Most areas, 85%, practice social rationing, so they don't allow couples or one of the couple has a child from a previous relationship to have medical help. It's appalling and cruel. Why is your right to medical help based on your partner's social status and not your clinical condition? And you may have seen me on the BBC Breakfast Sofa last week discussing how unfair this is. There are also additional age barriers. Some areas, 12%, say no to women under 40, and some of these say no to women under 35. And, you know, what reproductive message is this sending to women? You need to make decisions about having children in your early 30s or forgo having medical help if you need it. If you look at HFEA data, it shows women having IVF have typically been trying for at least 4 years. So are we saying in these areas, these women should start planning and having children by the time they're 31, just to be sure? Single women, only 1/3 of areas have an NHS pathway for single women, and it involves paying a hell of a lot of money for between 6 to 12 IUIs to prove your infertility before you can go on to have IVF. A round of IVI can cost up to £1,600. Paying for 12 of those, we're talking £20,000 before you can even think about accessing IVF. And some areas actually say single women have to provide additional evidence about themselves in order to substantiate the need for them to have treatment. And finally, female same-sex couples. This picture is improving. Most areas now do offer a pathway to treatment, but it still involves proving infertility at great personal expense to the couple. Although there are a handful of areas, just 6%, but they now state that same-sex couples can access NHS IVF directly without having to prove their infertility. And on this point, I should say about the government's promise in last year's Women's Health Strategy that it would remove non-clinical barriers to NHS fertility treatment, which would improve the picture for female same-sex couples and step-parents with fertility problems. But as yet, the government hasn't said when or how this is going to happen.
Our next speaker and final speaker is Sarah Norcross, who probably needs no introduction, but she is the director of PET and spokesperson for the PET campaign, The Power of 3 IVF Cycles. She's also the commissioning editor of BioNews and host of the Progress Educational Trust podcast.
The PET Power of 3 campaign aims to improve choices for people affected by infertility. And our campaign follows the World Health Organization's report, which states that addressing infertility is key to helping people reach the highest attainable standard of physical and mental health. And earlier PET research into public attitudes showed widespread support for the provision of NHS-funded fertility treatment to people who are infertile and wish to conceive. So it sort of ties in with the research that Chris has already shown. And I think this sends a strong message to government and to commissioning bodies in the UK that there is public support for this. And as the other speakers have said, the NICE guideline on fertility is similarly clear. If you're a woman aged under 40 and you or your partner have infertility, then you should be offered 3 full cycles of IVF. So PET commissioned research specialist 2CV to carry out survey work with the generous support of Ferring. I have to say, Ferring had no input into any of the work that we did. We just pitched the idea to them and then we did it and delivered it. And this research was in order to explore the understanding of the NICE guideline at the very start of the patient's IVF journey, because the gatekeeper to referral for IVF treatment in England is for many their GP. And this GP will in turn apply criteria that is set by the NHS commissioners at the relevant integrated care system or integrated care board, such as Penny. who we've heard from. And as we've heard from Catherine, people seeking help from fertility problems are embarking on a journey that can be very demanding financially and emotionally and physically. And this is made worse by a lack of understanding among GPs and NHS commissioners as to what constitutes a full IVF cycle. And this lack of understanding contributes to poor commissioning decisions, as Catherine has alluded to, resulting in a situation where most people receive less NHS-funded treatment than the NICE guideline recommends. So in this presentation, I'm focusing on the results of 194 GPs who were surveyed in May this year, and we started our investigation by finding out about getting referred. So we asked, to the best of your knowledge, when are women aged under 40 able to be referred for NHS-funded IVF treatment by your practice, etc. And our survey said the most common responses were after trying for 1 year and immediately if there's a known cause of infertility. And more than 60% of respondents agreed that these patients should be referred. But that's only 60-odd%. 37% of respondents did not indicate that a known cause of infertility or reduced fertility would be a trigger for referral. I'm not sure what those patients are supposed to do. And what shocked me, and I've been around in this field for quite some time, so I'm not so easily shocked, was that the profile of your GP can make a difference to your referral success. So, for example, where there was this known cause of infertility or reduced fertility, only 52% of male GPs said they'd refer people for treatment, compared to 73% of their female counterparts. We also asked about knowledge of the NICE guideline. So, to the best of your knowledge, how many full cycles of IVF are recommended for women aged under 40? And the survey showed that about half GPs, well, half, 50%, stated 3 full cycles are recommended for women under 40. But more than a third thought it was fewer than that. And this problem with a lack of knowledge about the number of cycles that are recommended is further exacerbated because of the lack of understanding of what constitutes a full cycle. So we asked, how many embryo transfer procedures should or do NHS patients receive as part of one full cycle of IVF? And the survey showed that whether it was as defined by NICE or in their local area, that 40-odd% didn't know. That was the most popular answer. But then perhaps slightly depressing is where the most popular answer after that was 1 embryo transfer. And perhaps that should be no surprise given what Catherine has just presented. So we wanted to survey the landscape and how they feel that the situation is changing, because it's very difficult to keep track of what's going on across, particularly with the change from clinical commissioning group to ICBs or ICSs. So we asked, in which of the following ways has NHS funded provision of IVF changed in your area in the last year or two? And orange is more restrictive and green is less restrictive. And as you can see there, the orange bars are mostly higher than those green ones. So 54% of GPs stated that the changes have been made in their area. And within that 54%, 74% report at least one criteria that has become more restrictive. So that's either been fewer cycles offered, tighter age range restrictions, other criteria such as BMI, and more restrictions around existing children from a previous relationship. And there's only one glimmer of hope here, and that relates to intrauterine insemination requirements for female same-sex couples, where the proportion of GPs reporting fewer restrictions is 8%, and the number reporting more restrictions is only 6%. So it's not exactly a great success story, shall we say. Then we asked GPs to rate access to NHS funded treatment in their area. And for this question, we actually gave them nice guideline for reference so they could see that and then rate how they did. Now, the survey showed, and again, I was shocked here, that 8% of GPs thought that the NICE guideline was being exceeded in their area. And if they're correct, which I very much doubt, I would probably, along with Catherine, love to take them out for at least a drink and say, well done. 40% of GPs believe that access to NHS funded treatment meets the NICE guideline. So this means that 48% think they're either meeting it or doing better than it. And as Catherine has said, the earlier research has indicated that only about 13% of commissioning areas in England offer the recommended 3 full cycles. So there's clearly a huge amount of confusion here as to what is going on, what their understanding is of what's going on and what should be expected. More than a third had some bit more in touch with reality, shall we say, saying that access to NHS-funded IVF treatment in their area falls short of the NICE guideline. And also, I think it's very disappointing the number, 14% who responded don't know how their area is performing for what is a vital patient service. And then we just wanted to sort of see what the level of pushback GPs were getting from patients. So we asked about how many patients they've been approached by with individual funding requests in the last 12 months. And the survey showed that 72% of GPs state they'd been approached by patients with these requests. And 35% of those have received individual funding requests from more than 5 patients. So a lot of people, I think, are not happy. And similarly with complaints, we see that in the last 12 months, 71% of GPs said that they'd received complaints from patients about NHS-funded IVF services. And 8% of those had more than 20 complaints about this issue. So moving on quickly now to our campaign. So because of what we've uncovered, and because before we asked the questions, we had a bit of a hunch, shall we say, about how this was going to go, that IVF cycles that are being offered are not full cycles, because there's this confusion, and I've noticed it over a decade actually, that there's confusion between a cycle and an embryo transfer, even though, as we've heard this evening several times now, but I'll say it again, that as defined by NICE, a cycle can incorporate several successive embryo transfer procedures. And it's not just GPs that don't understand what the guideline recommends. When I presented PET's data at the Fertility show last month, none of the patients in the audience understood that a cycle involved successive embryo transfers when you were talking about what should be available on the NHS. And if patients don't know what's recommended, they don't know to ask for it and to demand it from people. So to help with the problem, PET has produced a simple leaflet which is an online resource as well as a paper resource, which will help people understand what this is. And you can download it from our website, and I hope there'll be links for how to do that in the chat. And if you don't find them or can't find it, then do get in touch with us. And we've launched this Power of 3 IVF Cycles campaign to highlight the importance of offering the 3 full cycles of NHS-funded IVF to make access to fertility treatment fair. So if someone you know, your patients, or you just think this is just unfair and you don't know anybody, that there's this failure to comply with the NICE guideline, then we need you to get involved with our campaign by emailing your MP and explaining the problem. To get you started, we've got a handy template on for you to use, which you can download from our website. We know what it's like with the blank page. So, and remember, you need to put your postal address in, even though it's an email, so your MP knows that you're a constituent. And as NICE updates its fertility guideline, I would really like to urge the people who are on the development committee to make sure that the new recommendations are crystal clear, particularly concerning cycles and embryo transfers, so that there's less room to misunderstand or, at worst, cynically misinterpret the guideline. If after nearly 20 years we've had a guideline, people haven't got their heads around this, then perhaps it's time for them to consider a new approach to make this easier. But whatever NICE do, I fear that it will fail if the government do not provide NHS England with the money for it to be implemented. And government only needs to look to Scotland to see what success looks like.
I do want to start with some of the questions that have come in about MRKH, which is Mayer-Rokitansky-Kuster-Hauser syndrome, a condition that causes women to be born without a uterus. And there's a number of questions, 2 questions here. So I wanted to acknowledge first their questions. Number 1 is Hasna, who's asked, why are women born with MRKH, a condition that is a cause of AUFI, not automatically eligible for IVF or egg freezing, similar to other women with AUFI? Perhaps. And then the second one, I might put them together. Why is there such inequity of access for women born with MRKH when it comes to IVF process, being born with MRKH, which affects 1 in 4,500 or 5,000? Why are we subjected to the postcode lottery?
These absolutely should be included. This is, a diagnosis of infertility, and so all options should then be open to them. So it's something that absolutely should be included, and I would hope that the committee now looking at the guidelines would be looking at this.
Well, no, I agree. And there are women who are born without the uterus. There are also women who can't carry a pregnancy because perhaps they've had pelvic radiation for childhood cancer, or perhaps they've had a hysterectomy, I know, an obstetric tragedy. So there are women who need to have IVF and the creation of embryos, but aren't going to be able to carry their pregnancy. And at the moment, they're all excluded. It's not in the NICE guidance that they're excluded. And so we do get requests. I would view it more as a form of fertility preservation, that we can do ovarian stimulation, we can store embryos, but of course, then you're going to need surrogacy. And the question is how much the NHS is willing to fund that. And at the moment, the funders say, we don't fund surrogacy and therefore we're not going to fund the embryo creation.
I think this is something that does really need to be addressed by the NICE committee to make sure that these women are not being shortchanged. I think, as Melanie said, there are 2 parts to this. There's a fertility preservation element, and that they're giving them of the option, but there's also then the surrogacy part. And I think that really does need to be addressed, otherwise it's, just falls foul of being discriminatory from the get-go.
How do you measure the impact of the policy changes? Do you have any evidence looking at the emotional and mental health effects of more inclusive funding?
Thank you, Helen. That's a really interesting question. And I think it's broader than fertility. It covers almost all health services. How do we understand how we spend our money and the impact that it's having and then the benefit? It's a really difficult question. And I think as the NHS is growing in closer relationships with a lot of its academic partners and the academic health networks, science networks, I'm hoping that a lot more work and emphasis will be done on this. And it's really interesting seeing that presentation from Dr. Chris Skedgel there about understanding what do we mean by value? What do we mean by impact? So it's very difficult at the moment. I think we've got quite limited resources. I think a lot more thinking is going into this so that we can have a much more rounded view potentially and trying to understand that. So I think the growth around health economics, the growth around research, the growth around how we try and understand and measure what people would say is a good outcome for them is really important. Have we cracked it? No way. But I'm hoping that this is an area that's really going to be growing and will increasingly feed into our decisions about how we plan and think about services.
And I'm going to follow on with another question that has been directed at you to ask, how did the ICB identify providers and what quality metrics are monitored to ensure that success rates are and continue to be in line with or above national averages? Is patient choice extended to those providers who haven't been commissioned?
Our review, we did not specifically, we weren't sort of changing our provider landscape at the time. So our review is focused on the policy area. When we're looking at policy, obviously all the providers in the UK are regulated by the HFEA and also CQC. So we rely on them and their assessments as to whether they're meeting the necessary rates, etc., and what the success looks like and what their role is in terms of as a regulator. In terms of who we will commission as a provider, this will vary area to area. Different areas have gone through different procurement processes, etc., to secure. So it really will vary. You really do need to talk to your local ICB and your GP to understand who might be provided. For us, we've got quite an open policy, and it will be a range of providers as long as they've got an NHS contract with an NHS body. So it is really quite complicated. So I would say people do need to talk more locally to that.
Dr. Chris, you are up next for some questions here that have been directed for you. One is regarding, this is from Beth Gillies, regarding your slide on health-related outcomes for those who have had a live birth from ART. Do you think these results could have been influenced by lack of emotional support during the ART pregnancies? She said, I have heard a lot of services which are very involved to the point of a viable pregnancy, but unfortunately offer no antenatal support for complications or stresses that can come with an ART pregnancy.
The process of IVF itself is very physically and mentally demanding. That puts a toll on your health. And then, yes, often making it through that difficult process and finding out that it's not all sunshine and roses once you have a successful pregnancy. The child screams in the middle of the night and you don't get enough sleep and you have a sore back. That there can sometimes be a disconnect between the idealized image that was built up in someone's head during the process of fertility treatment and the miserable reality of sleepless nights. And that perhaps can have an extra impact on people who took the time and the energy and the effort and the financial burden to go through that process. That reality sometimes can hit them a little bit harder, perhaps, than someone who didn't have to go through that process to achieve a successful pregnancy.
I mean, having been both an IVF clinician and an obstetrician in the past, and I could see people through their journey and the psychological effect, the impact of their fertility journey influencing their perception of the pregnancy, and also in a very practical sense as well. They're slightly more likely to have complicated pregnancies and need more input, and they really do need that psychological support.
So Penny, what evidence do you use when making decisions about commissioning fertility services? Do you commission research?
So we don't commission it, that's not part of our responsibility, but certainly looking at that wider evidence base and understanding some of those changes that may or may not be happening was an important part to gathering that overall evidence base to us to inform our policy decisions.
I just want to say, as somebody who works in the area that Penny Mitchell works in, we have seen improvements. Bringing all of those CCGs together was a big task, but actually it resulted in levelling up of provision. So, locally, that has been a good thing. And because I look after women from a very wide area coming in for specialist care, I've also seen in some other areas things have changed. There was an area south of the river in southeast England that opened up to provide the IVF component for couples that needed egg donation, that they hadn't done before, but it was pressure from the patients who were under our care, and also the knowledge that other areas were doing it, that led them to revise their policy.
There's a question from Karen Harrison. Is guidance the same for PGT? I work for a rare disease charity where PGT is available for families to ensure that they don't have a child affected by these life-limiting diseases.
PGT is about testing embryos to make sure that one's not passing on heritable disease. So couples coming for PGT aren't actually infertile. And so we didn't consider them in the NICE fertility guidance. But actually PGT is funded through in England through NHS specialist commissioning through a genetics pathway. Couples still have to meet the criteria such as not being smokers that you would have to for other forms of IVF, but it's got separate protected funding.